Thank you to the organizers of the meeting for inviting me to speak in the GCC HIV Clinical Forum. My name is Dr. Paul Sachs. I'm professor of medicine at Harvard Medical School and Brigham and Women's Hospital. And I'm delighted to be able to share with you today key clinical trials data from the Dolutegravir studies. Here are my disclosures. What I'd like to do is review the key clinical trials of Dolutegravir. It's allowed me to go a little bit back in memory lane and go over some historical perspectives. And then I'm going to discuss the most important clinical trials and why they're important, including a wide variety of populations in HIV medicine. Let's start with studies in treatment-naive patients. But first, that trip down memory lane. Back in 2009, in the winter, the Conference on Retroviruses and Opportunistic Infections was held in very cold Montreal, and someone at GSK informed me that he's extremely excited about their investigational integrase inhibitor, which he just called 572, but had that very long name. Later that year, in the IAS meeting in Cape Town, I reviewed some of the highlights of that meeting, and I mentioned the following. GSK 572 investigational integrase inhibitor looks promising. With the relative dearth of drug development in the HIV field, it was great to see this presentation of 572, a once daily integrase inhibitor that showed a maximum HIV RNA suppression of 2.5 log with only a 50 milligram dose with no major adverse events, a nicely demonstrated dose response curve, no selection of drug-resistant virus, and even in vitro activity against raltegravir and alvitegravir-resistant viruses. A very promising start indeed. Now, with this beginning, and then after some phase 2 data, we saw some data from treatment-naive studies, and I'm going to focus, for the purpose of the first part of the study, on the single study. Now, the single study was a paper published in the New England Journal of Medicine in 2013, but actually had been presented before that. The title of the paper is Dolutegravir plus abacavir lamivudine for the treatment of HIV. And it was a randomized clinical trial of dolutegravir, abacavir lamivudine versus tenofovir FTC efavirenz, which, as you know, was standard of care for treatment of HIV for newly diagnosed patients globally. The results were actually quite spectacular. As you can see, there's a faster viral load decline for the dolutegravir arm, and then also 88% were successfully treated at the end of 48 weeks versus 81% for those in the efavirenz arm. And this was not just meeting the criteria of non-inferiority, but also the protocol-specified criteria for superiority. So in additional findings, in addition is that dolutegravir, as I mentioned, was superior to efavirenz, fewer adverse events, no emergent resistant mutations, and faster HIV RNA decline. And writing again on the New England Journal of Medicine Journal Watch site, I wrote, "We must note that this is the very first time anything has beaten an efavirenz regimen, and it's not for lack of trying. Starting with its surprising defeat of indinavir way back in 1990, efavirenz has subsequently bested fosamprenavir, lopinavir, ritonavir, nevirapine, nalfinavir, and abacavir, but not dolutegravir." There were several other early treatment-naive studies, the Spring 2 study, which showed that dolutegravir was not inferior to raltegravir, the Flamingo study, which showed that dolutegravir was superior to darunavir, ritonavir, especially in patients with advanced disease, and the ARIA study, which showed that dolutegravir was superior to atazanavir, ritonavir in women. Notice fewer adverse events compared to the protease inhibitors, and all of the studies remarkably showed no emergent drug resistance. Truly a first for an integrase inhibitor-based regimen. Let's shift now and talk about dolutegravir-based antiretroviral therapy in Africa, the NAMSL and the ADVANCE studies. These also were comparative clinical trials looking at dolutegravir versus efavirenz, and here non-inferiority was demonstrated in both of the studies. You'll note that in the NAMSL study in particular, there were many patients who had baseline viral loads that were very high. And this is one of the strengths of efavirenz-based treatment, And you note that dolutegravir did just as well. And clearly over here in the advanced study, the same thing is found. So let me summarize what these studies show. Let me summarize what these studies show. Dolutegravir is clearly non-inferior to efavirenz. It has fewer reported adverse events. It has a lower risk of emergent resistance with virologic failure. And this is particularly notable in the high viral load group, which had a high risk of developing resistance to efavirenz or the components of tenofovir FTC efavirenz. An additional finding, which was unanticipated, was significantly more weight gain in the dolutegravir arms, especially when combined with tenofovir alafenamide. What about studies of dolutegravir compared to bictegravir? Now, there have been two major clinical trials. I was the lead investigator on the second of these, 1490. 1489 was one pill versus one pill in a blinded fashion, dolutegravir, bacavir, lamivudine, bictegravir, FTC, TAF. And 1490 really just looked at dolutegravir plus TAF FTC versus bictegravir plus TAF FTC. The results are really quite similar in all strategies. Non-inferior in primary virologic outcome, no emergent resistance to any of the strategies. The weight gain was similar in the study arms, as were the metabolic changes, and there were minor differences in reported adverse events that probably don't mean much in clinical practice. Now, I put this meme here up because dolutegravir and bictegravir look very similar in many regards. But one place where they are different, of course, is that bictegravir is only available as a co-formulated product with FTC and TAF. Then the dolutegravir high resistance barrier was taken to the next logical step when it was combined with lamivudine. And this is the Gemini study results showing that dolutegravir plus lamivudine, given as separate pills here, actually was non-inferior to dolutegravir plus tenofovir FTC. These results are similar out at the 96-week point, and these results have now been extended further. There was one case of emergent resistance with long-term follow-up in the dolutegravir lamivudine arm. And allow me to discuss a bit about the use of dolutegravir in treatment-naive patients and the remarkable lack of resistance that occurs when that's done. So there have been some case reports of dolutegravir-related resistance occurring in treatment-naive patients. But just the fact that there are case reports shows how unusual this is. As you recall, for triple therapy studies for initial therapy, there has not yet been a single patient who's developed dolutegravir resistance in any of the clinical trials. There have been two patients in clinical trials of dolutegravir lamivudine who have developed integrase resistance, one in the ACTG 53 study, and the second in the paper that I just mentioned, the Gemini study, long-term, there's a patient who developed integrase resistance, but it's very rare. So what does it take to get integrase resistance from triple therapy with dolutegravir? What it looks like a high viral load and a low CD4 cell count, and then if you can add a bunch of other things. So we've got advanced HIV disease based on lab and active complications, concomitant rifamycin in two of the cases, which may lower dolutegravir levels, poor adherence in at least one case. And so I would just say at the outset, dolutegravir-based initial regimens, when given as triple therapy, lead to resistance extremely infrequently, very, very uncommon. Dolutegravir lamivudine, we have less experience, but it also is uncommon. But as I said, there's clinical experience with dolutegravir lamivudine as initial treatment is much less robust than triple therapy as initial treatment. So switching now to treatment-experienced patients with virologic suppression. And here we have four major studies: Striving, SWORD, Tango, and SALSA. And let me start with the discussion of the Tango study, because that's the one that has been most thoroughly explored. And this is a randomized open-label phase 3 trial of patients with virologic suppression who were stable on a TAF-based regimen and had never failed and had no resistance. They also could not have hepatitis B, because remember, we should include tenofovir in all our patients who have HIV hepatitis B co-infection. They were randomized to continue randomized to switch to dolutegravir lamivudine or continue their TAF-based treatment. It was an open label study, as I mentioned, and you'll see most of the patients at the baseline regimens were on an integrase-based regimen, especially elvitegravir cobicistat. The results show that switching to dolutegravir lamivudine clearly was non-inferior to staying on the TAF-based regimen, whether you look at the proportion who have a viral load greater than 50, or the flip, the secondary endpoint, the one where people are counted as success only if they have a viral load less than 50. This is more of a virologic failure endpoint. Virologic failure is exceedingly uncommon with this strategy. So let's comment about all of these studies in aggregate. The key results is that all 4 of these switch strategies showed non-inferiority to continued antiretroviral therapy. All of them did. There was one study that had some emergent resistance, and that was dolutegravir rilpivirine. The remainder of the studies have not shown this. The metabolic changes tend to favor dolutegravir lamivudine if the baseline regimen contains a booster. And remember, in the TANGO study, there was quite a bit of use of elvitegravir cobicistat, and patients switching to dolutegravir lamivudine had improvements in their metabolic profile. In addition, there was significant weight gain in some of the studies, and that would be most prominently noted in the recent SALSA trial, where dolutegravir was chosen as a switch strategy from any baseline regimen. And about half the participants in that study actually were receiving tenofovir disoproxil fumarate, often with efavirenz. And we now know that switching off that regimen often leads to weight gain. And here there was no use of tenofovir alafenamide. So the likely cause of the weight gain is the switching off of TDF, especially with efavirenz. I think that this study will be extremely interesting, and it's called Paso Doble, and it's ongoing right now in Spain. It's looking at a strategy of dolutegravir lamivudine versus bictegravir FTC TAF as maintenance therapy in people who have suppressed HIV RNA. It's like the others, a non-inferiority trial. And the key thing is that they're going to look at some very interesting endpoints. They're going to look at the mechanistic pathways involved with weight changes and what they see in terms of weight changes. They'll do a sort of aging study, a senescence study, looking at telomere length, because we're trying to see what are the safety benefits of using dolutegravir lamivudine in place of bictegravir FTC TAF. And there's also going to be a fat biopsy sub-study to see whether there's anything looking that's different between the 2 arms. I think it'll be very interesting because right now, what we're seeing is that dolutegravir lamivudine is clearly non-inferior virologically to continuing on triple therapy, whether it's TAF-based or not TAF-based. But what's not quite clear is, are there benefits or risks from the secondary endpoints of these sort of metabolic and aging and inflammatory markers? There's been a lot of discussion about potential changes in inflammatory markers, switching from 3 drugs to 2. But I think right now, those data are actually just suggestive rather than conclusive. And this study will give us a much better idea. All right, switching now to the next topic, which is treatment-experienced patients with virologic failure. I'm going to highlight the Nadia study, but I'm just going to summarize the Sailing, Dawning, Nadia, and Viking studies quickly. And then I'm going to talk in more detail about the Nadia trial because it's so important. Here, dolutegravir really has shined. Dolutegravir was superior to both raltegravir and lopinavir ritonavir. In the Dawning study, dolutegravir was so much better than lopinavir ritonavir that study needed to be stopped early based on this Data Safety Monitoring Board not thinking it was ethical to proceed with the randomized component of the study because the lopinavir arms were doing much worse. In the Nadia study, which I'll discuss in more detail momentarily, dolutegravir is non-inferior to darunavir ritonavir, even when you have no active nucleoside reverse transcriptase inhibitors. And then what we saw in the Viking trial, this is the only salvage study done in patients with integrase resistance using another integrase inhibitor. And what the Viking studies showed us was that dolutegravir was twice daily, was very active against some raltegravir and elvitegravir resistant viruses, in particular those that have the 158H mutation or the 92Q mutation of raltegravir and elvitegravir. Ultimately, of course, if you stay on those failing regimens with the first generation integrase inhibitors, you'll develop resistance to dolutegravir also. So let's take a look now at the Nadia trial, because I think it is actually very important. It was an open label randomized trial in patients with virologic failure on a first line regimen of an NNRTI plus 3TC plus tenofovir. The primary outcome was viral suppression at week 48. And let's take a look at the study design. It was one of these factorial clinical trials where there were two randomizations. The randomization number one was to either dolutegravir or to boosted darunavir. Of course, protease inhibitor-based regimens are standard of care for this population. And the second randomization was to continue the, quote, failing tenofovir 3TC or to switch to zidovudine lamivudine. So there's two randomizations, which means 4 arms. And if you look at the baseline characteristics of the patients in the study, they had an extraordinary amount of nucleoside resistance. So this really asked the dolutegravir and the darunavir to do a lot of the heavy lifting with the viral suppression. 50% of the patients already had resistance to tenofovir by K65R, 86% to lamivudine by M184V. As you can see, 58% with tenofovir resistance, 18% with zidovudine resistance, and yet, despite this extremely high level of resistance, the results were really outstanding, and they are shown on this slide. Here, what we see is at week 48, 90.2% of the dolutegravir arm versus 91.7% of the darunavir-ritonavir arm had virologic suppression. And if you take a look at this forest plot, darunavir better, dolutegravir better, and you take a look just at the number of active nucleosides, patients who had resistance to both the nucleoside components, you can see there's barely any difference between the darunavir and the dolutegravir. Really, really remarkable. Now, there is one caveat about this study. There were 4 patients in the dolutegravir arm who developed resistance to dolutegravir, and those were people who actually did not have good adherence to their therapy. So it's not impossible to develop resistance to dolutegravir, but you have to work at it. And these patients clearly were not adherent to their therapy. Nonetheless, this is really an outstanding result for the dolutegravir arm. And I really believe will probably lead to an alteration in standard of care, not just for people with virologic failure, but people who are switching who have extensive nucleoside resistance. So other studies in this category, I already mentioned these results. So I'll just say again that the most impressive thing, I think, is that dolutegravir is just as good as darunavir, ritonavir, even when there are very few active nucleosides or none. And my last group I'd like to talk about are the pregnancy group. And the pregnancy group, pregnant women really fall into a special population in HIV medicine. And the trial I wanted to highlight was the IMPACT 2010 or VESTED study, which compared dolutegravir versus efavirenz, and dolutegravir here was given with either TDF-FTC or TAF-FTC. So what this study and the DOLPHIN study showed was that dolutegravir was superior to efavirenz in viral suppression at delivery, a lower incidence of emergent resistance, and that this regimen, dolutegravir plus TAF-FTC, was the safest treatment to start in pregnancy. So let's take a look at this IMPACT 2010 study. Pregnant women, mostly in sub-Saharan Africa, were enrolled if they were treatment naive, and they started a regimen of dolutegravir plus TAF-FTC, dolutegravir plus TDF-FTC, or a standard of care of TDF-FTC efavirenz. And then they were followed during the course. They started treatment at around, they were actually, some of them were already on a baseline amount of TDF-FTC efavirenz before they were randomized, but still, this was a study of new starts of people who were treatment naive, except for a couple of weeks, 14 days of treatment was allowed. And the primary endpoint was viral suppression at delivery, and the secondary safety endpoint, well, actually, it's not a secondary safety endpoint, the primary safety endpoint was pregnancy outcomes. So the study, as I mentioned, did show that the dolutegravir arms were superior to the efavirenz arms for viral suppression of pregnancy. What they also showed was that the TAF-FTC dolutegravir arm was the safest of the 3 regimens, when you looked at adverse pregnancy outcomes. And that's seen clearly in this figure. This is the TAF FDC plus dolutegravir arm. And not only that, but it was shown that it was sort of mediated by a normal increase in weight, and that the pregnant women who started TAF FDC dolutegravir actually gained weight that was closest to the recommended amount. So as a result, when we now look at the pregnancy guidelines, what we see is that the pregnancy guidelines now recommend dolutegravir at all stages of pregnancy. So this is really good news. What we now have, as I said, antiretroviral therapy for pregnant people who've never received treatment. Dolutegravir is preferred, and the same is true for women who are now trying to conceive. Dolutegravir is preferred. So to summarize, there's abundant data supporting the use of dolutegravir in people with HIV across the disease spectrum: treatment-naive patients, treatment experienced with suppression, treatment experienced with treatment failure, and in pregnancy. The high resistance barrier is evident in all comparative clinical trials. It's useful for both 3-drug for initial therapy and 2-drug therapy, I think in particular as a switch strategy. The issue with integrase-related weight gain remains unresolved. It's actually an important ongoing scientific question, and one that I'm sure we'll hear more about in the coming years. So thank you very much for your attention, and thank you again for inviting me to speak.